thankful that everyone's able to join me tonight. I think this is going to be a fun topic to discuss, and we'll be taking questions at the end, so please save your questions. And always remember, anything that we discuss here is not intended to be medical advice. It's just sharing of information. Obviously, if there's a specific issue that you need to have addressed, please make sure you see a professional medical provider. All right, so let's talk a little bit about who we are. The Ortho Team Clinic, we're a legacy practice that's been in the Madison area and surrounding areas for over 40 years. We have two locations, one in Stoughton at the hospital here. The second one is on the west side of Madison in the Research Park area. We have options for in-person and telemedicine healthcare. We have a phone number and a website that can help people find more information as well as make appointments. So who am I and why am I qualified to even talk about this topic? I'm a board certified orthopedic surgeon. I've been in practice for, needs to be updated, but over 17 years of practice. I'm board certified in both orthopedic surgery and sports medicine, and involved in comprehensive knee and shoulder care. And of course, today we're going to be talking about knees. A little bit about on the background for today. ACL surgeries we know can be devastating, and for everybody, this may seem obvious, but ACL stands for anterior cruciate ligament in the knee. And ACL injuries can affect all age groups from young to old, and we know that prevention is a great part of it. If we don't have these injuries, that's the best thing possible. But we're also today going to talk about what are some new advances specifically in ACL surgery. It's estimated that in the United States alone, approximately 200,000 ACL injuries occur. And a recent estimate indicated that that's a $3 billion cost in the US to the whole entire treatment and reconstruction process for those 200,000 individuals. So it's an expensive endeavor for us as a society, as well as the number of people that it affects. What's interesting is, although we know many people who've had the surgery, and we think it's a successful surgery, that the numbers really are that 82% of the individuals that have the surgery actually return back to sports, so it's not 100%. And only 63% return actually to their pre-injury level of function. So they come back, but they're not as good as they were before. And out of that number, if we take a look, only 44% return to competitive sport. So although we think this has really been a great surgery and a great way to get back to sports, we really haven't met the bar in terms of getting the outcomes that we want. We know that young females are generally at risk 2 to 6 times higher than males, but since there's more males competing in athletics, there's more males that have tears overall. And there are certain factors that tend to put females at risk more, and many of those involve landing mechanics and how they jump and land and how their muscles activate. Most injuries that we see for ACLs happen are non-contact injuries or indirect contact injuries. So that means that no one actually hits the person, they just land awkwardly, and that causes this type of injury. And like we talked about with some of the risk factors that occur with females and males as well, is lower extremity biomechanics, so how people tend to land and what muscles are activated at that time. Well, what is the ACL anyways? As I mentioned, and we can show here in the pointer, in the middle of the knee here are these two ligaments that crisscross, and they're called the anterior cruciate ligament, the ACL, and the posterior cruciate ligament, the cruciate standing for cross. So they cross back and forth, and the ACL is the one here in the front. Now there's 4 main ligaments that support your knee. 2 of them are here in the middle, the ACL and the PCL, and then we have the MCL, which is abbreviation for medial collateral ligament, and we have the LCL, which is the lateral collateral ligament. So kind of in a basic term, there's 4 ligaments that stabilize the knee. And the ACL really provides a lot of rotational stability, so it doesn't allow your knee to pivot. And it's really important for cutting and twisting activities, including pivoting activities, which a lot of sports involve. So the mechanism of injury that we see most often, like I said, is non-contact in 70% of individuals, and it's usually during landing or a quick change in direction, and also when they land, it's in that more of that flat-footed position with the knee straight, and also in a knocked knee type of position. So if you were ever to see a video of someone in non-contact ACL injury, there's going to be a lot of similarities between those types of injuries. And what ends up happening is, because they tend to land flat-footed, that force comes straight up through from the heel up the tibia, and then exits out through the knee, which then results in the tear of the ACL. An important part of talking about ACLs is ACL prevention programs. As much as I like to take care of patients who may have ACL tears, we'd be far better served if we work on prevention so that we don't have these problems. We have a robust amount of science behind that, and many different research endeavors have been done. Over 2,000 different studies have been performed on ACL prevention, and they've been very successful, and most ACL prevention programs now will reduce the risk of an ACL tear somewhere by 51 to 62%, which is roughly half. And so if we can do that, that really can significantly decrease the number of ACL injuries that we have, and I think a good amount of our effort should really focus on that. Screening tools can be done at the community level with athletic trainers and coaches, and then these programs, once implemented, can be taught and supervised by obviously someone who has specific training. So what happens when someone tears their ACL? Well, they'll usually have this non-contact direct landing. They'll usually hear this loud audible pop. They'll have rapid swelling of the knee. They won't be able to bear weight on their knee. So these are very classic symptoms for someone who's got an ACL tear. But sometimes in some patients, it won't be classic. They may not feel the pop. They may not have the same amount of swelling. And sometimes in those cases, that may be someone who had a partial tear before and now becomes a complete tear. But this is more the classic way that we see an ACL tear present. So where do you start if someone were to have these types of symptoms from a non-contact landing? Obviously RICE, so we're resting, ice, compression, and elevation, get crutches, and then main thing is to get evaluated. And who can evaluate you? Obviously, if you're on the sidelines for a sports team, at any level, if the athletic trainer is present, they will be qualified to be able to make some initial assessments. Obviously, other options are trip to an emergency room or urgent care. Seeing a sports medicine specialist, I think, is important to diagnose not only this injury, but to make sure there aren't accompanying injuries with it. In addition to an ACL tear, you can tear the other ligaments in your knee at the same time, or you can have other injuries, including cartilage and meniscus tears. So all those things need to be addressed. So early on, like I mentioned, you can have significant swelling, and that can sometimes preclude a provider from having a good exam of the knee, just because a patient may be stiff and swollen, and that may not allow for a great exam. So sometimes we do need that swelling to lessen before we can really have a good exam. We are going to get extra studies. One, we want to get x-rays just to make sure that there isn't a fracture involved. That may change the treatment. And kind of the best one that most providers are going to look at is going to be an MRI. MRI is going to be able to take a look at ligaments, meniscus, cartilage, muscle, tendons, and bone. So it kind of gives us the best look at everything. So if there's going to be one study that's the best one to obtain, it's going to be an MRI. Next question is, so if you've been diagnosed with an ACL tear, is it good to hurry into surgery and do it as fast as possible, or is it good to wait? We know that if there's no additional injuries and it's just the ACL, it's okay to give it a little bit of time, especially to allow swelling to resolve, to get range of motion back and build up strength. And so many times, if we know that's the only injury, we'll get patients in with physical therapy and make sure that we work on getting their range of motion back and their swelling to go down before going into surgery. Now, in certain cases, if there's additional injuries, some of them can be time sensitive and they may force our hand to get the things a little bit sooner. Next question is, do I need surgery for my ACL? Well, I think the overall goal is any patient wants a stable knee. And so the goal is that if they have an unstable knee, to make it a stable knee. So in a young patient, we know that having an ACL tear not only leads to instability, but that persistent instability can lead to other injuries, including meniscus tears and cartilage injury. So those young active patients are gonna be more prone to having other injuries. Now, as patients age, maybe in their 50s, 60s, 70s, they just may not do the same type of cutting, twisting activities that as a younger person might, and therefore they may not need their ACL. And so if their knee feels stable to them, many of those patients we can treat without having to do any surgery for the ACL. So what are the options when it comes to ACL surgery? I think the two main ones that we talk about outside of not doing surgery period involves one, repairing the ACL, so taking the tissue that's torn and repairing it back. And we've seen that over the years as being less common because we know that reconstruction has been the gold standard and still considered the gold standard. And what reconstruction means is actually taking tissue from another area around the knee usually, and then using that to make a brand new ACL for a patient. So here's a slide actually I used from a presentation back in 2021, and it says, it talks about ACL repair, that it's less commonly performed. It's not possible if it's torn in the middle, and we know that newer advances are on the horizon and the results may not be as good. Now, I said that in 2021, and the science has really advanced over these last 4 years, and we see that now we can repair more often because there are better tools to allow us to do that, and repair is possible also from the middle of the ACL. It doesn't have to be just torn from the top end, and the results are showing great promise in that they're coming out equivalent in terms of ACL versus ACL reconstruction, and we'll go over that. So the one that we're really talking about today is, as our title had mentioned, we talk about the BEAR implant, and the BEAR stands for Bridge Enhanced ACL Repair. And with that procedure, what happens is the ACL, which you see the torn ends of the stump, we're able to pass stitches in it to repair it. And then in addition, we add the BEAR implant, which is a collagen implant that kind of acts like a Band-Aid to help those edges that are repaired back together heal. And that healing can, really take good effect even in a period of 8 weeks. Reconstruction obviously takes a little bit different angle on this. What we're doing is we're making a brand new ligament by using a tendon from elsewhere in the body. Or the other option is to get tissue from a cadaver. So those are the two main sources if we're doing reconstruction. And if I can show you here in this picture, the main sources over the years have been a few different ones. One is the patellar tendon, which is a tendon below your kneecap. And so taking the middle 1/3 of that with a piece of bone from the kneecap itself and the tibial tubercle down here. Then after that, kind of what's become most popular for a long time has been hamstring. And so with the hamstring, you can see here from the side of your knee, you have 2 hamstring tendons, and we're able to use those and also reconstruct your ACL. And what's become more popular these days, and when I do reconstruction, many times I'll use this quadriceps tendon graft. So we have different sources throughout the knee that we can use, but when we do an ACL reconstruction, I'd like to say we're robbing Peter to pay Paul. So we're taking something good out of somebody's knee to fix something that's bad, and there's no such thing as a free lunch, and there's consequences to that, and we'll go over that. And when do we use cadaver grafts? So mostly we're going to use those for older patients or with patients who have multiple ligaments that are injured that need to be reconstructed, because there's only so many we can get from a person's own knee. We need to make sure that when we do use cadaver grafts that we have ones that are thoroughly and rigorously tested by the American Association of Tissue Banks. We know there's always risk when we're using cadaver tissue, but that risk is fairly low. I tell patients less than 1 in 1.5 million. We do know that since the body sees it as foreign tissue, not in the sense that it would reject it, like we would consider like in a kidney transplant or liver transplant, the body does take longer time to incorporate and heal that tissue because it doesn't see it as its own tissue. So we do know in younger age groups that there's a higher risk of re-rupture versus an older patient, and that number could be almost 3 times or 3.5 times higher. The BEAR implant's a little bit different in how it does things. So one way we talked about is doing an ACL reconstruction. We replace it with a graft. Other way that we did it many times also too is a primary repair, where we're just fixing the ends together. Many times it was just torn off the bone. We were able to do that. And again, only in real select situations. So kind of a second place. But third place now, the new tool that we have in our toolbox is the BEAR implant. We're able to help the ACL heal by being able to repair it and then protect it to allow it to heal. So it creates a good environment, kind of like I said, like that Band-Aid or Miracle Grow to kind of help it heal. So replace, repair, or restore. When we do a primary repair, like I talked about, most of the time it has to be torn right off at the top of the ACL, because that way we can place stitches in there and then be able to repair it right back down to the bone. But with the BEAR, early on, they'd recommended only looking at tears up top here, but as time has gone on and more patients have been studied and more research has come out, we found that there are specific use cases to use it when it's been torn in the middle or more at the bottom, and those results have been very promising as well. But you do need to have enough tissue here at the bottom to be able to hold some stitches, so we can't have it quite all the way where it's pulled off the bone at the bottom. What's really critical for healing once an ACL is repaired is to be able to form that blood clot. If we take a look here, we describe the MCL, and the MCL is a ligament on the inner side of the knee here, and that sits outside the knee joint itself and outside the joint fluid. So when you tear that, you create a clot, basically a scab, over that injured area, which then brings all the healing factors to allow it to heal. Now, in the knee, for an ACL tear, it won't heal by itself because the synovial fluid, the fluid that bathes the inside of the knee, really prevents that scaffold of a blood clot to be able to bridge that. And that's why we don't see natural healing of ACL tears. Think of it as if you had cuts on your hand, but all day you worked as a dishwasher and they were wet all the time. Well, those cuts would never heal because there isn't a good environment for them to heal. The same is true of the ACL in the middle of the knee. But if we create a right environment for it, there is great potential for it to heal. And that's where the BEAR implant comes in to be that provisional scaffold. So what we can see here, I just have to adjust my screen here, is that when you compare the MCL and the ACL, what we see is that in many ways it's very similar, and it has that ability to heal, but it doesn't perform that scaffold, and that cannot be bridged, and therefore it doesn't have that same intrinsic ability to heal on its own. So the BEAR implant was developed, you can see a picture here of Dr. Martha Murray through Boston Children's Hospital. Through decades of research that she and her group had performed, they use a decellularized type 1 bovine collagen implant that holds blood, protects the clot, and prevents really that joint fluid, that synovial fluid, from penetrating that area and degrading that clot that forms. And we know that the science shows that by 8 weeks, you really get new native cells growing in to the ACL and new cells populating that area. So what happens with the surgery is that BEAR implant actually, before we place it in the knee to protect that area, we actually combine it with the patient's blood to then create that type of collagen scaffold, as well as having blood that will perform a clot, and that then protects that area. That resists the fluid from degrading the repair, and then allows your body to heal it, and then allow those cells to kind of move back in and allow for healing. And there's a great amount of literature and evidence showing how well the BEAR has performed. There's been over 35 preclinical studies that were performed, level 1 and level 2 clinical studies, additional level 1 studies being enrolled in right now. There's a worldwide evidence registry, 44 preclinical publications, and 11 peer-reviewed clinical publications. I think at this time, the data is, I think, somewhere near 4,300, 4,500 of these surgeries have been performed, and with good clinical results. So it's not something that just started yesterday, and it's not something that just has a small number of people in an experimental manner. This is something that has really had great data, has been thought through very well, and the results have been very promising. And Dr. Murray actually received the OREF Clinical Research Award, which is a really high honor to receive for her work in developing the BEAR implant. The Bridge Registry is a registry that was designed to assess the real-world performance of the BEAR implant. They looked at a lot of different outcomes. They measured surgery time, the type of tear, pain, how pain was managed after surgery, in terms of a therapy protocol, quality of life, re-tear, etc. So a lot of different factors that were looked at. And this was conducted at 30 different sites with up to 750 patients. And many of them also had MRIs that were performed at certain intervals. And you can see on these pictures here, there's initial mid-substance tear here, and then following out at 3 months. And then at 12 months, you can see the ACL there, and as well as at 24 months. On these MRIs also, they're able to see that the volume of the ACL was also comparable to their opposite knee, and that's obviously great support in terms of the repair process. And the implant itself was reabsorbed by 8 weeks, and these are just histological studies on slides showing that the BEAR implants were placed by new collagen blood vessels and native cells. Now let's take a look at the level 1 clinical study results at 2 years. They show equivalent outcomes. The knee laxity and patient-reported knee scores, so IKDC, those were compared, and the BEAR implant rated superior, had better hamstring strength at 6 and 12 months, and that trend sustained at 2 years. KOOS scores, which is a knee outcome score, and pain and symptom scores at 12 months were better, and 4 times more of the BEAR implant patients felt more confident with their knees at 6 months. And there was a trend toward lower tears of the ACL on the opposite knee, which is something that we do see quite often. Is after ACL reconstruction, we have to really be careful that they don't have a ACL tear in the opposite knee. They also will talk about potential reduction for osteoarthritis in the knee. And then also another concept we want to look at is, how do we burn no bridges, knowing that we can do a surgery that, if in the future were to fail, that we could then take the next step without having any detriment to that. So here, if we take a look here in research that was done, this is with Dr. Murray, looking at in these cadaver models, looking at with the ACL being completely transected and torn, development of osteoarthritis changes here. In an ACL reconstruction, we can see there is still presence of osteoarthritic changes, not quite to the extent of a torn ACL, but still there. And then when comparing it to BEAR, then we're seeing that that's not present at all. So, but these again are animal studies, and only time is going to tell us, because we'll need 6 to 10 years to evaluate for in patients in clinical trials. So why even consider using the BEAR implant? Well, it preserves natural anatomy, and we know in many things in orthopedics that we do, the more anatomic, meaning the more kind of the way God made us, if we can put things back together that way, we will do better. So we're preserving the natural anatomy, the alignment of the joint. We're preserving the original biology. The other thing we also know is that when we do an ACL reconstruction, we take out the original ACL, and those original ACL cells have nerve fibers in them that actually help us in our brain determine where our body is in three-dimensional space, called proprioception. And so it kind of gives feeling to our knee. And if that feeling is lost with an ACL reconstruction, you can imagine then it's not going to feel normal and natural. And maybe if we preserve and keep our own ACL, then we can keep that in place. Next, we're not robbing Peter to pay Paul. We are not taking a graft from another site in the knee or from a cadaver. So we have less pain from that. We mitigate any risks involved from taking a graft from elsewhere. And also is if a BEAR implant in the future were to fail, we can go ahead and perform an ACL reconstruction without really any benefit, which is without any detriment, which is obviously much easier than if we did a full ACL reconstruction and we have to revise that to another reconstruction. That's a much more difficult surgery, and especially for the patient, and we know the outcomes aren't as good. And then there's also, we talked about the incidence of potential decreased risk of osteoarthritis. So overall, we know the BEAR implant gives us a chance to do things better, because I think the reality is that although we think ACL reconstruction is great, we know that it has certain limitations, and if we can do it better, then by all means we should try to improve the lives of our patients. So in terms of implant patient selection, when it comes to the BEAR implant, we know that in different groups, we still want to have a pretty conservative protocol, and that we don't want them to return back to sports for 9 months for all ages. And it may be a great alternative for people on both ends of the spectrum, not only the younger athletes, but also then the older weekend warriors as well too. And if we take a look so far in that BEAR registry data, we know that 39% have been under 18 years of age, 42% in 19 to 39, and then 19% in that 40 plus group. And then if we further divide in terms of the registry by where the tear is, the tear that's up higher, proximal tear that's 33%, mid-substance 57%, and distal is 10%. When we look at the therapy that's involved afterwards, we start off with partial weight bearing, so only 50% weight bearing with crutches, and we can wean them as early as 4 weeks. So up front, this is definitely slower than what we would have for a general ACL reconstruction, in which we let people bear weight as much as they want. We know that they usually don't want to for the first couple weeks anyway, so overall it may not make a big difference. But we do have them stay in a post-operative brace for 6 weeks, but we do begin immediate home PT and begin 4 weeks post-op with a formal physical therapy program. And then we kind of outline here how long they'll be in therapy, but we do not recommend return to sports with the BEAR implant for 9 months. So if we take a look here at the BEAR 1, so there's been multiple iterations of research that's done. So there was BEAR 1, BEAR 2, BEAR Moon, and then beyond. So if we look at the first BEAR 1 data outcomes, if we look at IKDC scores, which are just overall scores, we know of how patients are satisfied and subjectively what they think of their knee. The BEAR implant scored a 92, while an uninjured knee scored 87.5. Both the ACL reconstruction and the original Moon group were lower. Hamstring strength on the BEAR group versus ACL reconstruction was better. And then also looking at 2-year IKDC, better with the BEAR. And then the KT1000, which is an instrumented test where we're able to measure how much laxity there is in the joint and front to back. And we found that an uninjured knee would have a 1 millimeter side-to-side difference. ACL reconstruction would have 1.6, and the BEAR was similar to that. So similar side-to-side difference. And again, BEAR outperformed in terms of hamstring strength. So outcomes are consistent. And then if we look at IKDC scores which indicates confidence in your knee, we take a look at with the BEAR 2 trial, 40% of patients had a score greater than 90, while in the control group, which was an ACL reconstruction, it was only 11% of patients had a score greater than 90. So we can see significantly higher scores in the BEAR 2 group. So more confidence that those patients had in their knee. Re-tear rates. Now, re-tear rates in this study for the BEAR 2, we did see that there was a higher re-tear rate at 2 years, and all of 7 of those 9 were patients who returned too soon and didn't complete their 9 month of rehab. So sorry, 6 of the 9 were before they were cleared. And in terms of the idea of burning no bridges, knowing that if a BEAR patient then goes on at some point to re-injuring and needing an ACL reconstruction, we know the results of that are very good. So if we take a look here, IKDC of a revision from a BEAR to doing a full ACL revision, they scored 89, while if somebody had a initial ACL reconstruction and then had a revision, their score was 77. So we know that this allows us to treat people without compromising their outcome subjectively. And if we look at objective, looking at a difference in how much motion or play they have in their knee, looking at, again, with the looking at their KT1000, we know that here on the BEAR revision group, only 1.4 millimeter side-to-side difference versus a primary ACL reconstruction overall. So even in a BEAR revision group, we can do quite well. So again, not burning any bridges. So I think in summary here, we know ACL injuries can be devastating. We know that when we do reconstruction, which has been considered the gold standard for decades, our results are good, but they're not great. And far less people return back to their pre-injury level of function and high level of sports as we think they do. We also know that there's a significant risk of developing osteoarthritis as time goes on. So the BEAR implant with an ACL repair offers a more anatomic solution. The results so far have been promising, and the data is just growing on it. But it's not for everybody. We know that not all tears are amenable to using the BEAR implant. So I think in my practice, the way I look at it now is when I see patients, and if based on their MRI and how long that they've been had a tear, we have that discussion, and we're really ready to perform either procedure based on what we see inside surgery. Another thing to add that I didn't include in the presentation was up until recently, the BEAR implant was only indicated for patients 14 and over, and also FDA had not approved it for partial tears. Just last week that has changed, and now the FDA has approved it for patients under 14 as well, and for a partial tear. So the indications are expanding as we're getting more and more data. Here's a little QR code if you want to snap a picture. It gives us even more information on how the procedure is performed and what it's all about. At this point, I just want to say thank you to everybody for being here. And obviously, if there's questions, I'm more than happy to answer those questions. Thank you.